there are a whole of things that have the potential of being a problem with ulcer disease. So let's kind of reflect on what that's going to be. And the things are age, smoking, alcohol, chronic illnesses, history of ulcers, aspirin, NSAIDs. Don't forget about the P2Y12, warfarin, etc. And there are a whole bunch of other things in addition. So the teaching point here is there are certain patients who are going to be prone to ulcers, and we really need to make sure that those patients are on chronic PPIs. We're going to talk about that at length, but there are certain patients, they're elderly, they're debilitated, they can be on warfarin, they can be on aspirin, NSAIDs, etc. They need to be on it. And we got to really concentrate and make sure that those patients are on it. On the other hand, and as we're going to be seeing in just a little bit, there are tons of patients in this country who are on proton pump inhibitors inappropriately. There are tons of them. My pharmacy friends, are you feeling that all the time on these patients? Okay, and we're going to find out why. You're going to share with us. You're going to share with us. Here you are. You're going to share with us why, if you feel up to it, why you need to be on chronic proton pump inhibitors. Because there's only certain, if you want to, there are only certain categories of patients who really need to be on chronic proton pump inhibitors. So we'll talk about that. So lots of stuff to learn about. Okay, the other thing that just came out, and I want to include that. I just had seen that recently. Inappropriate aspirin use. Remember, aspirin now has been cut back it's not the primary prophylaxis. It should not be primary prophylaxis for cardiovascular disease. It should be secondary prophylaxis. So look at these figures. 45.6% of older adults were taking aspirin in 2019 despite updated guidelines. That's unbelievable. What an incredible risk factor for ulcer development in the future. And we clinicians are always surprised of asking patients, are you taking medicines? And they'll list their other medicines and, a baby aspirin, that's not really a medicine. 81 milligram, that's not anything significant. So we have to always make sure of what they are taking and what's going on. So here we go. Who needs chronic PPIs? Let me help you with that. Who needs chronic PPIs are high-risk individuals on anticoagulants, NSAIDs, etc. As we had just said, recurrent esophagitis, recurrent ulcers. These are the people absolutely who need to be on it. And there's a whole bunch of other things. My clinician friends, I'm sure you have concerns. I bet a lot of you have difficulty of getting some of these on pump inhibitors once they're on it. It's almost like an addicting, you're shaking your head, right? It's like an addicting substance, right? You just have tremendous difficulties. You want to share?
It's not addicting, it's just that it makes you feel the problems come back.
Right.
It's not like you have to.
From the get-go, but there is an algorithm that we can use to make sure that that patients do improve. And okay, so the side effects of PPIs. We talked about that just a moment ago, right? There are side effects of PPIs, and I left you off with that one that is absolutely proven. Which is the absolute? I kind of left that hanging. What's the absolutely proven side effect of proton pump inhibitors? Caused by? Nope, sorry. Diarrhea caused by? Wow. Okay, I got the special ones for you guys back there. Okay, so hold on. hold on. You got one already, but you didn't get one. All right. C. diff. C. diff. That's the one big proven side effect of PPI. And so I made it an easy algorithm for you guys to understand. Red, problem, like a red light. Orange, caution. Green, go. So red is the only one out there, and Clostridium difficile is twice as likely in long-term proton pump inhibitor use patients as otherwise. So think about this. You're giving, let's say, busy clinician, proton pump inhibitor, I'm going to give that to a patient. I've got to worry about their kidney thing and their heart thing and their a gazillion other problems. I'm going to concentrate on their other medicines. Well, God forbid you get Clostridium difficile twice as likely over time. You're not going to feel very happy about that, are you? Right? So that's the important message. Now, for extra credit, and I got all kinds of other things over here. So all kinds of other things over here. Is there another caution with regard to proton pump inhibitors? Any other things that I didn't mention over here? That's a special extra credit for you guys. There are two others that I want to mention. Pneumonia. Anybody hear of pneumonia from proton pump inhibitors? That was a thing in the past, so I'm glad we can take that off the table. Magnesium deficiency. Anybody hear of that? Off the table. So that's completely off. In fact, I used to do lectures with, 3 things. So I'm glad nobody knows about it. Don't worry about it. Let's talk about this. The orange stuff. The orange stuff. When we're talking about myocardial infarction, stroke, renal failure, there are probably, I would say 6 or 8 or 10 of these things out there that can possibly be a side effect of proton pump inhibitors. Think about it this way. And again, when we get together at our national meetings, and I attend an awful lot of national meetings with many of our thought leaders, almost all of these studies are not double-blind controlled prospective studies. They're retrospective studies, okay? So think about it that way. And think about it when it's a retrospective as opposed to a prospective study. Who's going to get myocardial infarctions? Is that going to be the young ones or the old ones? Who's going to be getting the stroke and the renal failure, young ones or old ones? It's an association. It's not a direct relationship. And that's what I want to dispel here because, again, the literature up to this point, it may change. The literature up to this point is pretty clear that there's a lot of hysteria with regard to proton pump inhibitors. And I always like to tell stories. And I'm sure you've seen that as well. A patient who just suddenly hears about this on the news or reads about it in the paper, and suddenly who has elderly, history of ulcers, history of using NSAIDs, aspirin, clopidogrel, just go on and on and on, reads about this kind of proton pump inhibitor problem and decides to stop it on their own. And I've had a few coming into the emergency room, with significant GI bleeds. And I'm sure you have as well. So we need to be totally aware of those kind of things. And we're going to develop that topic a little bit more here today so you totally understand that. The interaction with clopidogrel, osteopenia, that's out. That's out. That's been out for years. And I'm going to show you a little bit more about that. Clostridium difficile, we talked about that. Here it is. And risk of development of C. diff in proton pump inhibitor twice as likely. So be cautious on whom you give chronic proton pump inhibitors to. Alzheimer's, no risk. And that was just shown in the last 2 years. And let's talk quickly about the clopidogrel. Those of you who have been in this field long enough realize that clopidogrel, when several years ago, there was a lot of concern about giving clopidogrel at the same time as proton pump inhibitors. And it's really been shown to be not a problem. We used to For those of you who remember, we used to separate out the doses. We used to choose certain, I see you, yeah, you used to separate out the doses. You used to choose the PPI, one PPI over another. That's all out. That's all out. So we don't have to worry about that anymore. The bottom line, what's the bottom line here? Zero risk of adverse effects. So we really don't have to get concerned about that again. So let us go into the bone fracture situation. Look at this. Retrospective. I hate those retrospective studies. They're just really not as good as the prospective double-blind control. And, you know, there's certainly ways of following this up over time. Association, not causality. And I want to thank our Canadian friends. In 2012, Targowick had put this all together. And I've really referred to this ever since, and it's been repeated multiple other times, where population samples were followed over time. Prospective, again, population sample of femoral, hip, and lumbar spine, baseline 5 and 10 years, huge numbers, 84-30, 45-12 at 10 years, proton pump versus no proton pump. Look at this, here we go. No change in bone mineral density with continuous PPI use. So generally okay. This is the scary part, and I want to share this with you as well. The scary part is in this particular study, majority of physicians recognized the known risk of PPI, I should say risk as opposed to risks, which is Clostridium difficile. High risk upper GI bleeding prevention, 79% recommended stopping PPIs. Wow. So now you know not to stop them. We can continue them for the appropriate patients. And this is all recent information. Here's another bit of information that I want to share with you. The other bit of information is proton pump inhibitor overuse. We talked about that before. Proton pump inhibitor overuse is significant. And again, it's the same reason we talked about before. Look at this. Proton pump inhibitor prophylaxis without indication in 66% of patients transferred out of the ICU. While the patients in the ICU, they're on 12 medicines. Again, it's the same kind of thing. What are we worried about? Are we worried about their cardiovascular status, renal status, et cetera, et cetera, et cetera? Or are we worried about a proton pump inhibitor that gets put way down on the list and they get shipped off to the floor because they were on ulcer prophylaxis and they don't really need it? And then even on the floors, look at the next part. Look what it says down there. Proton pump inhibitor prophylaxis without indication for 35% discharged home. Same kind of story. You know, let's go through the 12 medicines that they're on that they really absolutely need. Proton pump inhibitor, I'm too busy. I've got a panel of 24 patients to handle here on the floor. And I just, you know, the primary care doctor, you know, it's always the primary care. The primary care, or I would say, because we have PAs and APRNs here, the primary care provider will take care of that. Well, the primary care provider is also very busy, as we well know. But again, the point here is just seek out those patients who really do need proton pump inhibitors versus those who do not. I bet you're able to peel away a whole bunch of proton pump inhibitors. And this is what I promised you. Ready? What's your name? Dr. Bridger. Dr. Bridger, this is what I promised you. And again, you can challenge me or just say if this has worked for you. Discontinuation of PPIs may be complicated by acid rebound. Acid rebound may be mistaken for occurrence of symptoms. And again, I remember a colleague of mine that used to, every time they took the patient off of a proton pump inhibitor, used to repeat an endoscopy. That doesn't sound very kosher to me. But the big problem here, and Dr. Bridger, I want to point this out to you, slow taper and H2 blocker. Pharmacists, yes, I'm looking at you guys. What's the half-life of proton pump inhibitors? Is it long or short? It's very long. It's very long. So here's the potential. So, and this is what I've always done over the years. So we can slowly taper. So by that I mean you can go to every other day. Let's say they're on twice a day. Then you can go back to once a day. Then every other day, every third day, maybe even every fourth day to see how they do. You can always supplement that with H2 blockers. And you can also supplement that with an old medicine. I bet you remember this medicine, Dr. Bridger. Carafate? Sucralfate? Remember that? Yeah. It's not too popular anymore. But again, any of these things, maybe even an antacid. This is a way of getting some of those patients off of the proton pump inhibitors and get them on to, being away from that. Because again, that Clostridium difficile has me a little bit concerned. We don't want that at the worst possible time when they've got something else going on. So there we go. Oh, you okay with that? Okay, great. I want to make sure. Okay, Rima. Okay, Rima is a 79-year-old who has an appointment with you for epigastric discomfort. She had 2 hospitalizations for endoscopically proven duodenal ulcers 6 months and 12 months ago, using over-the-counter NSAIDs for her arthritis. And physical, you can look this over, nothing too exciting over here. You tell her to stop the NSAID, you prescribe a PPI. But let me go back to the story because the story will help you with regard to the next part. So Rima, epigastric discomfort, 2 hospitalizations, endoscopically proven duodenal ulcers, using OTC NSAIDs for arthritis, and this is one of these situations where she's not on proton pump inhibitors. And so we're coming to the question. Ready? Does Rima need an endoscopy? Does Rima need an endoscopy? We're going to vote. Who says she needs an endoscopy? Put your hands up. Who says she doesn't need an endoscopy? Who says, I just want to have lunch? Okay. Let me hear from those who said she does not need an endoscopy. Some brave soul. Hemoglobin is stable, and there's more information. She had an endoscopy. Yeah, she had an endoscopy. That's exactly right. So I'm going to come over here because I want you to get this. And it says, I got it. That's how I would approach it. Again, they're very, I know you're looking for one of these as well. Here's the point. So I'm not telling you how to practice because again, some of you may feel comfortable in, doing another repeat endoscopy. Maybe it's something else. And I'm never going to say how to practice, but in my estimation with that history and without being on a proton pump inhibitor, I would say it's pretty likely that that's going to be going on. And here's what I would do. I would follow it over time. I'd follow her H&H over time, check her symptomatology. And again, it's unlikely that it's going to be a gastric cancer or a Barrett's esophagus or an esophageal ulcer or something like that. And if she feels better, that's fine. That's how I would do it. But again, I'm not telling you how to practice. If you feel you want to get another endoscopy just to be sure, that's fine too. Okay, so it's just a personal opinion. Okay. Here's a great thing, because this has come out in the last few years. And again, our hospitals are all overloaded right now. So it's going to be really important for you guys to know some of this information. And I don't expect you to become gastroenterologists, but I expect you to just know that there's certain patients who can be safely sent from the emergency room. And let me show you why. Do all patients with an upper GI bleed need to be admitted? What do we think? Who says yes? Who says no? Who says I'm not sure? Okay. The answer is not everybody needs to be admitted. So what we're seeing here is a very shallow ulcer without the kind of concern that we have, and you'll see that in just a moment, of what concerning ulcers look like. And just to show you, these are the criteria that we use. Do all patients with upper GI bleeding need to be admitted? No, we look at certain criteria. And again, for my medical students and interns and residents, we use a Blatchford score. That's the technical term. But for those of you who are clinicians, this is what we're looking at. So obviously, if they are massively hypotensive, renal disease, that their H&H are low, no, there's no way that I'm going to send them home. that they had syncope, hepatic disease, or heart failure. No, there's absolutely no way that I'm going to be sending them home. But this is the criteria that we look at. So every once in a while, we get, a relatively healthy individual who does not have a significant change in any of these things, who can readily be sent home. And let me show you a little bit more about the concerning criteria. Let's see, can we get the lights down in the front here so we can see this a little bit better? Is that possible? So here on the left-hand side, over here, this is a big vessel. It could very well be a vein or an artery, and that whenever we have that kind of thing going on, we get very, very concerned because the likelihood is extremely high that there's going to be difficulty in the future. And here's another one. This is a vessel, so this is really prominent. This is another vessel that is of concern. And the bottom line here is it's a whole different situation than the first ulcer that I had shown you. So non-bleeding visible vessels, look at these figures. So 43% chance of bleeding without therapy, but even 11% chance bleeding with therapy. So we need to be concerned. Oh, thank you so much. That's great. Yeah, that's much, much, much better. So let me show you those pictures. So you see it a little bit better. So the big vessel over here as opposed to a smaller vessel, we're still of concern in both of these when we're doing the endoscopy. Okay, what do we say to this one? Are they necessary? No? I would say I would qualify that in general, no. But if they're massively bleeding and they're just constantly vomiting up blood, yes, I would put down an NG tube. So again, I want to be very qualified with regard to that. You know, it's a melanotic situation. They vomited a few hours ago at home. Nah, and we're going to talk about why it's not necessary. But if they're just heaving, constantly heaving, yeah, let's put down that NG tube, a wide bore NG tube, to just clean them out. So that's the answer. And if we don't use NG tubes, how do we clear the stomach prior to an endoscopy? The answer is, does anybody know? The answer is erythromycin, which is a powerful prokinetic, 250 milligrams IV, 30 minutes prior to an endoscopy. So that's how we clear out the stomach. Okay, clinicians, here's what we need to do. And I want to present this to you. Why I present this to you? Because the paradigms have changed. I remember I've been in this field for a gazillion years, and I remember when we didn't have criteria, and these criteria have come out really recently in the last few years, 3 or 4 years. But before we had these criteria, I would rush over to the hospital 2 o'clock in the morning, 4 o'clock in the morning, 6 o'clock in the morning, we're going to show you why that's not necessary in most situations. Because again, it's a pro and a con kind of thing. And let me show you what's going on these days. So what's the optimal time to do an endoscopy for an upper GI bleed? So obviously I'm leading to the answer here, which is within 24 hours. Not necessarily right away to stop the bleeding. Sometimes it is. If you're thinking about a varicose bleed, you really need to get to that pretty much right away. But if it's not a varicose bleed, it's within 24 hours. So here's the reference that just came out, and I want to share that with you. Patients with upper GI bleeding should generally undergo endoscopy within 24 hours to optimize the information that we're going to be getting. So why do we not necessarily need to do this at 2 or 4 in the morning? Because the patient may not be adequately resuscitated, may not have gotten enough blood in their system, their blood pressure may not be in optimal range. The other thing, and I remember this in particular, our endoscopy suite in my hospital, which is in Connecticut, was so far away from the central part of the hospital that if we ever needed to call a code, people wouldn't even know where to find us. So think about that. So 2 or 4 in the morning, that's pretty scary when people don't know how to find us. Fatigue, that happens to all of us, and lack of radiology and surgery backup. So all of these are really good reasons to do it more electively. Are we okay with that topic? Do we have questions? Because now we're going to move on to the next topic. H. pylori. So H. pylori, let's do it. What percentage of all ulcers are due to H. pylori? 25, 50, or 85? Who says 25? Who says 50? Who says 85? Who says the price is right? Step on down. The answer is 85%. 80, it's that high, 85%. So let's talk a little bit about H. pylori. And there's a whole bunch of stuff that I want. Here's one of the most important messages that I want to share with you. So as for my clinician friends, and again, my pharmacy friends as well, those patients who have gotten the quadruple antibiotics, you can always remind them they need to be followed up. They need to be retested. Clinicians, they need to be retested for sure, because the amount of retesting in this country is abysmal at this time. We've got to do a much better job. So let me tell you a little bit about the epidemiology. We're going to get through this entire process so you really understand a lot more about H. pylori. H. pylori acquired in childhood. Likely you can see what that it's fecal oral transmission. Look at that prevalence. Typically asymptomatic, unless eradicated, will be present for life. And what does H. pylori cause? What are the problems? What's it directly related to? Cancer? Malt lymphoma. Oh my goodness. You've been quiet up till now. Here we go. I'm going to give you something special. You need to read this to everybody. I hope I give you a smile. Read this nice and loud to everybody, please.
Has nothing to do with chocolate.
Okay, that's the epidemiology. So let's talk about this. And you already got this. So the answer here is, which of the following are potential consequences of H. pylori? Gastric cancer, malt lymphoma, and esophageal cancer. So MALT stands for mucosal associated lymphoid tissue, and it's basically lymphoma, and a lymphoma that is responsive to antibiotics. And we're going to talk about antibiotics in a little bit. But it's the only lymphoma that is responsive to antibiotics. So there's a direct relationship. So think about this. Think about this perspective. So if you don't retest that patient, and we're going to get into how many patients are continuing to have the infection and how many are really cured. But if we don't retest them, they have that potential, low though it may be, of getting gastric cancer or malt lymphoma. Let's continue. This is one that I really want you to know about. Should patients with GERD be tested for H. pylori? What do we think? Yes or no? Who says yes? Who says no? And the integrity question, who says I'm not sure? Okay. The answer is no, they do not need to be tested. And I'm going to show you the reason why, and you're going to always remember it. You're going to always remember it. So here's the situation with H. pylori. H. pylori reduces the acid in the stomach. I'm going to repeat that. H. pylori reduces the acid in the stomach. So curing H. pylori will obviously increase acid in the stomach, and increasing acid in the stomach will do what to GERD? Increase the GERD, right? So we shouldn't test that. We shouldn't test that. Let's go to the next one. How about this one? Should we consider H. pylori testing in those patients who will be on long-term aspirin or NSAID therapy. I see some of you shaking your head. What do we say, yes or no? Yes. And the answer is, once again, yes. Because again, it's a way of preventing trouble in the future. All right, so this is for my clinician friends. And let me take a zip, so wet my whistle a little bit. So for my clinician friends, which of these tests should no longer be used to evaluate H. pylori? Endoscopy and biopsy? Let me come to this side, better sound. Endoscopy and biopsy, breath test, serum test, stool test, which should no longer be used to evaluate for H. pylori? Serum test, why? Because?
Antibody.
It's an antibody and?
Potentially, if you've ever been exposed.
Aha, very good. And it's potential if you've ever been exposed. And it really, let me give you a little bit more detail. Where do you practice, may I ask? First of all, what's your name?
Josh Walker.
Dr. Walker. So where do you practice, Dr. Walker?
Georgia.
South Georgia. What's the prevalence of H. pylori in South Georgia?
I mean, I don't know the numbers, but it's pretty high.
Oh, it's pretty high. Okay. So if it's pretty high, there's still potential. Because again, let me give you an example, and I'm gonna tell you a little bit, because your situation is very similar to my situation. I live in Manchester, Connecticut, which is right outside of Hartford, Connecticut inner city. The prevalence of H. pylori in Hartford is about 50%. The prevalence in Manchester is about 10%. If I do a serum test in Manchester, they're going to be false positives. If I do a serum test in Hartford, it's probably pretty good. So if you happen to be in an inner city situation, serum test is okay. So it's still okay to use, but in general, it should be very, very selective. So the original answer was absolutely correct, but there'll be situations where you can still use it. So the key here is knowing what the overall prevalence is in your community. So you're absolutely right. The serum test is the least accurate and probably should no longer be used because, again, people can't keep up with the prevalence of what H. pylori is in their community. So urea breath test, in case those who are doing them in the office, to just make sure. Remember that this is not a nuclear test. This is easy to do in the office and will give us the information about what's going on. So Lily, age 68, has been found to have a benign gastric ulcer. Helicobacter is present. Which antibiotic regimen should we choose? Which should we choose? Anybody have ideas? Let me go and tell you where we're going to be. Empiric therapy. So think about this. So my clinician friends, think about this. If we have an infection in the year 2022, a blood infection, an abscess, something like that, we're always going to do culture and sensitivity, right? That's how we do it. Urinary tract infection, respiratory tract infection, culture and sensitivity. Well, we don't have that same ability on checking for Helicobacter in the year 2022. We will. I'm going to show you some things that are on the horizon. But for right now, we're going by the seat of our pants. So it feels like we're in the 1950s here, right? We're just kind of throwing this at patients, hoping that we're going to have the best kind of results. So usual treatment of bacterial infections is guided by in vitro sensitivity, local resistance data. We're wrong about 30% of the time, which is part of the difficulty. And incomplete adherence to that antibiotic regimen leads to more resistance. And here, just as a way of reflecting, there's lots of resistance. The most important is clarithromycin. We used to give this like water all the time, and we've kind of moved out of that direction. We used to also give levofloxacin like water as well as another alternative measure until we found out about tendon problems, etc. And we still do give metronidazole. Let's continue. How to select the appropriate antibiotic regimen. Most parts of the United States have clarithromycin resistance, and that's been the problem. So it probably should be out the door for right now. Metronidazole and levaquin as well, but we still use metronidazole, and I'll tell you why in just a little bit. So we think about quadruple therapy. So quadruple therapy is a big problem. So what is clarithromycin resistance, and why is there clarithromycin resistance? Look at this, because we've been giving azithromycin like water, right? How many azithromycins do you prescribe in a winter season, right? It gets the overhead of the pharmacy well over the top, I'm sure. So that's been part of the problem. But part of the other problem is other antibiotic exposure. So here's the success rate. So what success rate when we're talking about Helicobacter treatment over 14 days, should not be less than 14 days. 14 days is the key. The business-based quadruple with tetracycline, 74, and the PPI, clarithromycin, amoxicillin, as I don't recommend, 58.1. Here is metronidazole and tetracycline. And it's interesting, remember I said before that I just wanted to make sure you're keeping me honest, that I said there's some metronidazole resistance. Metronidazole in combination with tetracycline and bismuth is still effective. So even though there's some resistance as opposed to clarithromycin, it still has effectiveness when combined with other products. Here's another one, there are many regimens out there. So penicillin allergy. So we pretty much know this, right? Penicillin allergies, some patients claim that they have a penicillin allergy and they really don't. The key here is more than 10% believe that they do. Most were reactions, not allergic in nature. If in doubt, an allergist can test. And that's certainly a very important concept to think about. So, pharmacy friends, have you had experience with this new product? No? Clinicians, experience? You know why? Who said that? Who said that? Okay, here, finish up the lecture. I'm going home because you already know. You get one of these, you get one of these, and you get one of these, which says, thank you very much. It's expensive. It's expensive, but look at this figure. So let's say, like to everybody here in the room, let's say you're getting, a patient that has had difficulty with other products. Look at this, 90.3% eradication versus 64.7 in this particular study that was done. So it's a nice backup medication product that's out there. So I want you to be aware of that. So you have a difficult, and that's why on Monday when you're going back to your practices, I want to make sure that you at least know about this, and you can talk about this with the gastroenterologist and say, my patient has a difficulty. Let's see if we can get this patient on this particular product. Okay, let's talk about some more stuff. Okay, future therapy. I don't usually do this, but I'm going to do that here because we're really on the cusp of a whole different approach to Helicobacter therapy. And I want you all to be aware of it. There's a product out there which is called vonoprazan, which is an acid reducer. It has a somewhat different mechanism than proton pump inhibitors. It is multiple times more effective than proton pump inhibitors. And there are a lot of studies out there that combined with antibiotics, much higher cure rates. Incredible stuff. And it may not even have to be a quadruple therapy. It may be triple therapy. Makes it easier on our patients. So I don't usually do it, but I want you to at least know this name for future use because we're in the cusp of this coming out, and that's going to change things around significantly. So what I anticipate, not only will it be more effective, but we may not have to do the 14 days. You know, how many of our patients can't do the 14 days? A good percentage of them. How many can't do the 14 days? How many people can't do quadruple therapy? Huge percentage. This is going to change everything, and keep your eye out. Aha. Who remembers this cartoon? What's it called? Thank you very much. And the names of the characters, please. Wow. I want everybody in this room, Charlene, everybody to get extra credit because they can identify everybody from the Jetsons. It's unbelievable. All right. Anyway, so remember what I said before, that, you know, this field is going to change dramatically. So what happens if I told you that just like for culture sensitivity, we're going to be able to be much more specific for our treatment? So fluorescent probes, PCR tests, and which may give us a lot better information about what's going on. Certainly we can do, you know, if you have a really difficult case, a gastroenterologist can do biopsies and send them out to Mayo Clinic or big university places, but it's not always covered, and it's a big process. So in the future, it's going to be a lot easier. We're going to get better identification, and we're going to have better medications. So that's what I expect. All right, let's talk about this. Reinfection rate, less than 1% once the patient has been cured. Isn't that great? But how many of our patients can continue on that 14-day regimen? Right, yeah, we all have that same problem. And reinfection rate for partial treatment. Oh my goodness, look at that, 85%. Clinical pearl number one, time and patience are critical when discussing why the first treatment failed and identifying what we should do next. So we got to spend that time with the patient. Here's the other thing, concerns, of course, adherence and risks, and never use the same treatment the second time. What percentage of patients report a side effect when taking quadruple therapy? Should it be 10%, 25%, or 50%? Think about those patients who you've dealt with. Who says 10%? Who says 25%? Who says 50%? Wow, that's the number, 50%. So no wonder. And that's why I wanted to just present to you what's going to be happening in the future. It's really frustrating for all of us, right? But in the future, it'll be a little bit easier. What's underneath there, what it's saying? What's the definition of pill burden? Pill burden. Does anybody have a definition of pill burden? Yeah, it's too many. You know, and we have it in all of our elderly patients. You know, you give an elderly 92-year-old patient a series of 18 medicines to take, and sometimes they need that many. It's pill burden. You know, they're not going to get all of that in. Here, it's clear. You know, we're giving them quadruple. I got to reward you. Hold on a second. I've got something special. And you said you made it easy. And pill burden. Obviously, if you're doing quadruple therapy, that's an enormous amount of pills that needs to be taken. So pill burden may be significantly reduced in the future using this vonazepam, far fewer antibiotics. Okay, let's skip over that one, and let's skip over that one. So more barriers. So pylori, as we know, is another one of those particular products out there that are easy to use. Talicia, which is the product that we talked about just a moment ago, rifabutin, amoxicillin, omeprazole, all in one. All of these are out there, but to make adherence a little bit better, but it's the cost that is keeping us away from all of that. Okay, so causes of refractory H. pylori, any sort of antibiotic exposure, as we can see. Little resistance to amoxicillin, tetracycline, and rifabutin. And this is from the latest criteria that we have out there. So, should we be retesting for H. pylori? What did we say before? What's the answer in unison?
Yeah.
Absolutely. Absolutely, we should be retesting because, again, we want to make sure that there's no potential for these bad things, the cancer or the multiple lymphoma, to occur. Retesting only occurs in 25% of the patients, and that's an astoundingly low figure. So why do we retest? The things that we just said before. Let's talk about Hannah. Hannah just finished her quadruple therapy for H. pylori and needs to recheck her H. pylori status. This is a more difficult kind of one. Which of the following is true? She needs to stop her proton pump inhibitors for at least 1 to 2 weeks prior to testing, or she needs to stop her antibiotics 2 weeks prior to testing, or no follow-up testing is necessary, or she can get an immediate endoscopy and biopsy. So it's a little bit more difficult. So it's just thinking about how, it's just bringing to the fore how to retest patients and what do we need to think about as clinicians. So how many of you say number 1? How many of you say number 2? And how many of you say 3 or 4? Okay. So the answer here is absolutely correct. She needs to stop her proton pump inhibitors 1 to 2 weeks prior. If testing is redone, and we hope that it is, antibiotics need to be stopped at least 4 weeks prior. At least 4 weeks prior to get an adequate and appropriate result. So stopping the proton pump inhibitors. And what are we going to do when we stop the proton pump inhibitors? When that patient is telling us about that dyspepsia, that their upset stomach, they just can't take it anymore. What are we going to do? No, we can't do slow taper. We've got to get them off of it. What should we do? H2 blockers. Once a day, twice a day, 4 times a day. As needed, you know, whatever it takes. That's the point, is whatever it takes in that short period of time. We can't do slow taper because, again, it has to be a cutoff because the proton pump inhibitors will themselves inhibit some of the growth. So we got to be off of that completely suddenly. So H2 blockers, we try as best as we can. And with the H2 blockers, don't forget about the stuff we just talked about. Carafate, sucralfate, antacids, any of those things to just get those patients by the next 2 weeks. Okay. Chuck, known history of duodenal ulcers documented by endoscopy 6 months ago. Don't worry, we're getting to a break very shortly. I know you guys are tired. We're going to get to a break very shortly. 78 years old, history of duodenal ulcers documented by endoscopy. Helicobacter was treated at that time. Now, despite taking proton pump inhibitors twice a day, still reporting epigastric pain and nausea. Exam is unremarkable. So what can cause this, this response? Let's go back here. So he's still having trouble, still epigastric pain. So what do we think can be causing this kind of trouble? Let me show you. Compliance, right? Is he taking it the correct way? How about alcohol? Always sneaking in the back door. COVID. What did we learn during the COVID era? The amount of alcohol is incredible. That's the statistics. 30 to 40% increased amount of alcohol during COVID time. And that's only the statistics. I bet it's much, much more than that. So alcohol. Aspirin NSAID use, recurrent H. pylori, another disease going on. So these are the kinds of things that we need to think about. Here are some additional references if you need them. The summary, chronic proton pump inhibitor use doubles the C. diff risk. 85% of all ulcers are due to H. pylori. 50% of all patients taking quadruple therapy report a side effect. Help them through the process in the ways that we had just talked about. Non-healing ulcers can be caused by alcohol abuse, medication compliance, and the continued use of aspirin and NSAIDs. And you guys have been great. Are there questions that we can answer before we take a break? Yes, ma'am. Okay, inflammatory bowel disease, what you need to know. So we're going to take you through this entire process. Same rules as before.